Hey guys, we're here to pass off our restraints today. So first of all, when we are going to restrain a patient, we need to assess whether or not the patient needs restraints. Reasons that we would restrain on our unit is if they are pulling on life-saving tubes such as an ET tube, their airway, if they are at risk for pulling lines, things like that. If they are climbing out of bed, we really don't want to restrain them with restraints. We'd prefer to get a sitter, reorient them, keep somebody in the room with them. But if we had to, we will restrain if we don't have any other resources. So first off, we're going to assess our patients. Do they need to be restrained? Once we identify the need for restraint, we have Cynthia, our patient, who has been really acting up. She's been swinging. So she's trying to pull her life-saving devices. So what we're going to do is we're going to get our restraints and we're going to secure them around the wrist, and we're going to use the least possible points possible. So we don't want to do all the arms or both arms, both legs. We're just going to do what's required. So we're going to do 1 finger width between the skin and the restraint. Then we're going to latch it shut with the clip. And then where we're going to make sure that we tie the restraint and anchor it is to an immovable part of the bed. So we don't want to tie it here. That's not going to do any good. And if we have to lower the bed, it's going to rip her arm off. Look at that. That's not good. So we want to go to the frame of the bed, right down here, and we'll just loop through. And what kind of knot do we want to do on you, Cynthia?
One that's not going to slip.
Well, we do the slip knot.
Oh, it's a slip knot. But
So that one that, yes, one that secures, but one that we can release easy. So it's a quick release knot. So we're just going to tie it through, make sure that we're nice and tight. But then if we need to, for any reason, we're going to do a quick release. So that's how we're going to secure it. We want it secured so that she can't really move more than 2 inches, because if we're trying to save her from pulling her breathing tube, we don't want to have a lot of slack, right? So we want to make sure that it's about 2 inches of wiggle room. And then we need to, but not too tight. We want it down below the hands, so not up high, because then she will also be able to pull out lines and devices. So the other thing we need to make sure of is we need to get a physician's order within 24 hours of using the restraint. We also then, after the restraints have been started, we need to assess every 2 hours minimum. We can do more if we need to. We're going to assess the skin. We're going to assess for blood flow, make sure the hands are warm. We're going to assess for a pulse, and we're going to let the patient have some range of motion, whether that's active or passive. We're also going to check reposition. We're going to check the 3-piece pain potty positioning and be aware of anything that might be causing the patient distress. Restraints are contraindicated on patients who have had a history of any kind of physical or sexual abuse. So we need to be aware of that so that we don't cause any undue trauma to our patients, and they might be more appropriate with a sitter. And I think that's about it with our restraints. So go ahead and pass it off with your charge nurse now.